Now come to the treatment. Treatment is very simple. If diagnosed on the time, simple is easy. The treatment is very easy. And the early and rapid administration of antibiotic, penicillin, benzyl penicillin is the treatment of choice, and still it is susceptible to the benzyl penicillin. And it is antibiotic of choice. But nowadays, third generation cephalosporin like ceftriaxone and ceftriaxone, these are the preferred class of antibiotic because of some penicillin resistance is now reported, and also ease of administration without any thinking of the penicillin side effect. Secondly, supportive care. Patient should be managed in ICU to manage the shock and multi-organ failure in the form of early ventilation, fluids and inotrope and steroids sometimes required. And chemoprophylaxis should also be given to the household contacts of sporadic cases, and it should be given within 24 hours up to the 4 weeks. So now come to the important part, that is the prevention. So prevention through the immunization, we know that vaccine is there, and vaccine is the definite source of prevention. So now two concerns is that one is the prevention from the specific serogroup, and second is the protection in the early age group. So to achieve the desired outcome, we need to provide the immunization with the vaccine that not only provide the protection in early age of life, but also to reduce the transmission or carriage if given in adolescent age group. Because I told you that adolescents are the most common spreader of this disease. So the target should be earlier, the early infant, and also the adolescent group. So in the team, what should be targeted? To target the both, which matter most, like one should target the serogroups which are responsible for the disease, and also the age group where it is very much common, to prevent the spread and also the disease mortality or morbidity. So there are two main classes of vaccine used for protection against the INT: pure polysaccharide vaccines and the protein polysaccharide conjugate vaccine. Both of these type of vaccine are based on the capsular polysaccharides of the meningococcal, which is a major virulence factor. Means the polysaccharides is the virulence factor, and it is primarily responsible for colonization and invasion by prevention of the host-mediated bacterial killing. Everybody knows the basic difference between the polysaccharide vaccine and conjugate vaccine. Polysaccharide vaccine responds very short duration. There is no memory cell production. But conjugate vaccine, there is a antibody protection or response is very long duration. There is a stimulation of T cells also. So cell-mediated immunity is also there. And also memory-based cell is produced so that in future there is a quick production of the antibody. And about the conjugate vaccine, the process, we must know that process is the same, that in this figure you can say there is a conjugate polysaccharide is isolated from the meningococcal. Then there is some purified carrier proteins is derived, and these are assembled to make as a conjugate vaccine. So by this process, many immunological advancement is being done. Worldwide available meningococcal vaccine and conjugate polysaccharide and conjugate vaccine are there. Various names are there available in various countries. And nowadays, mostly conjugate vaccine are being used. The polysaccharide vaccine is used only where there is a non-availability of the conjugate vaccines. So now come to India. In India, what is happening? We used to follow the reactive immunization patterns, or particularly in the high risk. Means whenever there is a need, we then think of that. It's called reactive immunization. But this approach has some limitations. Like we know that some outbreaks reported are very abrupt and short-lived. Secondly, the immunological delay after the immunization during that time, and good number of cases may happen even before the initiation of immunization. So the COVID-19 had changed the way of our thinking. We look forward the vaccine preventable diseases, and vaccine, as knowing the vaccine meningococcal is a vaccine preventable disease and outbreaks are uncertain, but immunization is certain. So we must ensure to immunize against IMD, which has the potential to cause an outbreak. And in spite of that, there are certain reservations toward this immunization in our country. In developed country, implementing meningococcal immunization program with adequate coverage has been effective in decreasing the burden of diseases. However, the similar result achievement in developing countries, particularly in our country, is hindered by several challenges. And similar, I told you when describing the Asian challenge during Asia, the similar here, that the lack of adequate epidemiology and surveillance data, unfavorable vaccine prioritizations, we do not give the priority of this vaccine. This priority comes slightly less because due to many factors like affordability and awareness also. Then certain limitation inherent in the meningococcal vaccines. Vaccine unaffordability, very costly. Conjugate vaccines are very costly. Not many persons cannot afford this. Also, data are scarce. The very limited cost effectiveness data. And there is an overcrowding of the immunization schedule. If you can imagine that any age group like 9 months, sometimes they started 9 months, there is many vaccines are at the time. Like flu is given, MMR is given, meningococcal is given. So if anything left in the primary stages of DPT combination, it's given. So there is an overcrowd every time in the initial phase of the life. It is likely that meningococcal disease is markedly underreported in India. So also there are the hindrance that lead to the not effective vaccination program implementation in our country. And two types of vaccine I told you now. A CWY capsular vaccine is there and some non-capsular vaccine. B is not available in Indian country. So this ACYW 4-valent meningococcal vaccine is there. It is derived from the capsule and conjugated with various carrier proteins, and it is available in the name of Minectra by Sanofi Pasteur. Here conjugation protein is the diphtheria toxoid. Similarly, one is Nemandix, although it is not available really, but it is conjugated with TT. It's not available and marketed in India. And second is the Menvio, where the conjugation protein is CRM197. So two conjugated vaccine is available in our country. One is the monovalent vaccine is recommended. You can say the schedule is there. It is manufactured in India, but it is not being used in India. So it is being exported to the African country. It is made by Serum Institute of India. It is a vaccination against serogroup A. Its name is Menvio. So it is only supplied to the African country. And it's very, very strange scenario here. We are in need of some, because serogroup A is the most common in our country, but vaccine is available, but we are unfortunate, we are not taking, we are not being supplied of this particular important vaccine. Now come to this slide. So now how this vaccination works. So this is the principle. You can see this slide, very important slide. The most important thing is that maintaining the protecting levels of antibodies by vaccination. This is required for the clinical protection, because after initial vaccination, what happens that circulating functional antibody level naturally begins to decline after some time. So if further booster vaccination does not occur, there may be a waning of the clinical protection over the time. Long-term protection after immunization depends on the maintenance of these mechanisms, like memory response, persistence of the functional antibody, and the herd protection. If immune memory is functioning properly, it will mount the defense against the recognized antigen. And with antibody and T cell in 2 to 7 days, these are the time period. In this interim period, the host relied upon the innate immune response to combat the infection. But in contrary, some diseases like hepatitis B, they do not require the high circulating antibodies because of their slow pathogenesis, because the average incubation period is 3 months, 90 days. So their innate immunity and high level of protective bacterial antibodies, these are the primary immune mechanism against disease is required whenever we consider about the fastly growing meningococcal disease. And when in future the immune system encounters this invasive infection, they stimulate a response from the memory B cells. There may not be occur quickly enough because protection resulting from this antibody raised by the B cell memory takes up to 5 days. So 5 days have to be taken to mount the antibody. And incubation period is only 3 to 4 days. So you can think that maintaining the presence of circulating functional antibody against the Neisseria meningitis, this is the may be necessary for the clinical protection. So here case is the different from the other similar or other bacteria which have the slow progression. So, okay. So as with other conjugate vaccine, you can see this graph, as with other conjugated vaccine, meningococcal conjugate vaccine are expected to provide a rapid, strong, durable post-booster response based on the principle of vaccination as I described you in the previous slide. So now we have two vaccines mostly we are using, that is the MenACWY quadrivalent conjugated with CRM protein and one each ACWY conjugated with the DT. So these are used, this is composed of all the 4 valent, and the DT combination is known as Menectra, made by Sanofi Pasteur. Second is Manvio, made by GlaxoSmithKline. These vaccine confers the direct protection as good as polysaccharide vaccine, but can also promote the anamnestic response, that is a memory boosting that I told you earlier, and reduce the acquisition of Neisseria meningitis, virulent strain, and the transmission. So what is the schedule and recommendation? Different countries have the different vaccination schedule. Currently, there is no agreed consensus on a single optimal strategy. Nevertheless, all schedules try to address the two things mainly. That one is the direct protection of the age group most affected by the IMT, and second is decreased carriage and the transmission. And ACIP US CDC has recommended from the age group 11 to 18 years, mostly first dose given at 11 to 12 years and one booster after 5 years to 6 years of age, means second at 18 years. Persons with having high risk condition, they should be vaccinated right from 2 years to 55 years of age. And in 2001, ACIP also recommended to MCV4 for 9 months to 23 months if required. And in that way, these two vaccines can be used in earlier less than 2 years also, but Manvio by GSK is only approved in our country to use from the 2 years age onwards, not below that. So what is the rationale of using it from 9 and 12 months of age? Because it addresses the unmet need of this age group. There is a better persistence of titer as compared to the 3 dose given in the infancy. This provides the clinical benefits, means cost versus quality of life saved, and it avoids the issues associated with the crowded vaccination schedule at 2, 4, and 6 months. And there is a high uptake which is seen in the various literature. So Indian Academy of Pediatrics still recommended this vaccine only for the high risk situation, like I explained in the earlier slides. And they have also in their immunization schedule mentioned that they just lower the age group of minimum as a 9 months. Earlier it was 2 years. Now they says that you can use from the 9 months till 23 months. In that case, you have to give the 2 doses at 3 months apart. And if you are using 2 years and above, then you have to give only 1 dose.